Hello, everyone. My name's Dr. Al Rundio, and it gives me really great pleasure to introduce our speaker today. I'm going to introduce Dr. Catherine Ferneely. Dr. Ferneely has a baccalaureate degree in nursing, a master's degree in public health, and a doctor of nursing practice degree in community public health nursing with an emphasis on addictions nursing. A public health nurse for 36 years, Dr. Ferneely has served in leadership roles at the city, state, and national levels since 1993 and has been certified in addictions registered nursing since 1999. She has served in doctoral internships at the Substance Abuse Mental Health Services Administration and the White House Office of the National Drug Control Policy. She has extensive state agency experience leading grant writing teams for community-based substance use disorder prevention and treatment programs. She is an associate editor of the Journal of Addictions Nursing and editor of the Policy Watch column. She co-authored SAMHSA's technical assistance publication, TAP number 30, Buprenorphine, A Guide for Nurses, and was a field reviewer for Treatment Improvement Protocol, TIP number 63, Medications for Opioid Use Disorder. Dr. Ferneely has served 4 previous terms on the INSA Board of Directors and as chair of the INSA Health Policy Task Force. She is now serving as the president of the International Nurses Society on Addictions for 2018 to 2020. Her interests include substance screening and brief intervention, pharmacological therapies, specifically buprenorphine, health policy, public health, and health disparities. So it gives me great pleasure to welcome her. I'm going to just do a couple other introductory slides, and then Dr. Ferneely will take over. She has disclosed no conflicts of interest, and we are funded as a partner with the American Academy of Addiction Psychiatry on a Substance Abuse Mental Health Services grant, which will actually end at the end of July this year, but it did receive refunding, and we will be doing this for another 3 years. We provide 4 webinars a year for the grant. So the overarching goal of Providers Clinical Support System is to train a diverse range of healthcare professionals in the safe and effective prescribing of opioid medications for the treatment of pain, as well as the treatment of substance use disorders, particularly opioid use disorders with medication-assisted treatments. So now I will turn it over to Dr. Ferneely, who will do our presentation today.
Thank you, Al. Good afternoon, everyone. I have 4 objectives for today's activity. First, I want to describe the role of suicide in the opioid overdose epidemic and explain the need for uniform case standards and case definitions for classifying drug-related deaths. I will be describing at least 3 other conditions that may interact with opioid use and exert cumulative effects to adversely affect individuals and populations at risk of overdose and/or suicide. And finally, I will describe how an awareness of syndemic theory can be helpful for planning appropriate interventions, advancing health policy, and improving health outcomes. So the purpose of today's talk is to describe the opioid epidemic as a complex phenomenon that consists of multiple related conditions that cluster and interact synergistically to exacerbate health effects, problem severity, and disease progression. So starting with the role of suicide, I became interested in this topic when I read some papers by Dr. Maria Oquendo, president of the APA. She did a congressional briefing about the opioid overdose epidemic and suicide. And then Dr. Nora Volkow from NIDA invited her to be a guest editor of Nora's blog in 2017. And they identified a relationship between opioid use disorders and suicide and said that that relationship between the two is a hidden tragedy. Consequently, the 2 of them, Dr. Oquendo and Dr. Volkow, published a paper in the New England Journal of Medicine about the role of suicide in the opioid epidemic and said that suicide was a silent contributor to opioid overdose deaths. So the premises of this talk is that there's a twinning of the opioid and other drug overdose epidemic and the suicide epidemic. And I contend that this is not the first or the only drug-related twin epidemics, and that the opioid crisis is a complex phenomenon that consists of multiple related syndemic conditions in addition to suicide. And we'll talk about what syndemic means later. Well, in a nutshell, you've heard of epidemic, but a syndemic is when two or more epidemics interact to have multiplicative or cumulative effects. And so there's multiple other related conditions that also interact in multiplicative and cumulative manners to adversely affect our population of interest. And so they would include pain disorders, ACEs, the adverse childhood experiences, post-traumatic stress disorders, HIV/AIDS, polydrug use and toxicity, social determinants of health, and many others. And there's a paper that mirrors this presentation that I wrote that's on the reference list at the end. So there's some, drug statistics that in 2017, over 70,000 drug overdose deaths happened in the United States. About 68% of them involved opioids. In 2016, it was over 63,000, which was up 21.4% from the previous year. And about 2/3 of those involved opioids, with the largest increase being in illicitly manufactured fentanyl. Over the time period from 2013 to 2017, drug overdose deaths increased in 35 of 50 states and the District of Columbia. And the most significant increases were in fentanyl-related deaths in 15 of 20 states studied. And so over the period from 1999 to 2017, over 700,000 people have died of drug overdose deaths, with nearly 400,000 of them involving opioids. About 82% of drug overdose deaths in the United States are unintentional or accidental. 12% of them involve drug overdoses that were intentionally, of the drug overdose deaths in the United States, about 12% of them were intentionally self-inflicted, which is suicide by drug overdose. So when we think about the opioid overdose problem, we don't always think about the role of suicide. And there's been a 30% increase in suicide rates in nearly every state from 1999 to 2016. And the self-inflicted overdose deaths involving opioids has doubled. And interestingly, more than half of the people who die by suicide have no known previous mental health condition. And we're familiar with the drug treatment gap, where people who have a substance use disorder need treatment but don't receive it. So only about 1 in 10 Americans who need drug treatment for illicit substance use receives it. 9 out of 10, or 89% of young adults age 18 to 25 who need treatment are untreated in the past year. And of adults over age 26, 76% of those were untreated in the last year. And so I like this quote by Lopez that says, "It's easier to get high in America than it is to get help." And there's a corresponding difficulty in obtaining help for depression and other mental illnesses. About 20% of Americans have had a mental health issue, and 4% of Americans have a serious mental illness, and half of adults with mental illness do not receive treatment. and you hear about them when there's a mass shooting on television. So people with mental illness have nowhere to go and find little sympathy from those around them, and the lucky ones find homes with family, but the unlucky ones end up in the morgue. So, you know, it's kind of like opioid overdose and suicide are kind of like a Venn diagram, and there's a portion of the deaths where opioids overlap with overdose, intentional overdoses or suicides. So what people with opioid use disorders and mental illness have in common is the lack of the barriers to the receipt of treatment, including lack of financial resources, lack of treatment capacity, shortage of treatment professionals, failure to recognize need for treatment, stigma, fear of disclosure, and racial ethnic disparities. So Dr. Oquendo, who did the congressional briefing and wrote Nora's blog and got me interested in this twin opioid overdose and suicide epidemics, mentioned 3 studies in her article, in her blog. And the first one looked at drug overdoses and suicide with an aim of exploring the link between substance use disorders and suicide mortality. She looked at 4.8 million men and women that were served by the Veterans Health Administration and found a significant association with increased risk of suicide for both men and women. But the relationship between suicide and substance use disorders was significantly higher for women. And it was even a stronger relationship when adjusted for co-occurring psychiatric disorders. So women with any substance use disorder or an opioid use disorder were at the greatest risk. Their risk of suicide increased 8-fold, and for men, it was more than 2-fold. So they concluded that substance use disorders are important markers to include in a suicide risk assessment, especially for women, meaning that we should be screening our substance use disorder patients for the risk of suicide. And the second study that Dr. Oquendo mentioned was the Ashrafione et al. Study that aimed to examine the relationship between past year frequency of prescription opioid misuse and past year suicide planning and suicide attempts. They compared those with no prescription opioid misuse to people who did have an opioid misuse, and they found that they were more than 6 times more likely to have suicide attempts, more than 5 times more likely to have a suicide, to have planned a suicide, and 4 times more likely to have suicide ideations. So the prescription, if they used prescription opioids weekly or more for any reason, they were more likely to have planned a suicide attempt and to have made an attempt. One of the limitations is that this study did not control for poorly managed uncontrolled pain or pain intensity, which are independently associated with suicide and pain should be part of the assessment for a patient's risk of suicide. The third study that Dr. Oquendo mentioned was by Wilcox and Connor and Kane, and that was a meta-analysis of cohort studies to examine the association between alcohol and drug use disorders and completed suicide. And they calculated standardized mortality ratios for suicide by comparing the risk of death for people that had an opioid use disorder with the risk of death from suicide from someone from the general population. And the risk of suicide death was more than 13-fold for people who had alcohol and drug use disorders. So it's important that we look at the way medical examiners and coroners classified drug-related deaths with a lack of uniform case standards and definitions, sometimes there's misclassification, and we're not really certain the extent of the accuracy of the prevalence and incidence statistics for suicide deaths and opioid deaths. You know, what percent of them may have been misclassified. So it's very difficult for medical examiners and coroners to distinguish between intentional and unintentional opioid overdose deaths due to these lack of uniform standards and case definitions that can affect reliability of the data. Part of the challenges are that they are not able to accurately determine the causes of death. They can't do cross-study comparisons, nor can we develop appropriate public health responses to reduce morbidity and mortality if we're uncertain of the cause of death. And another thing that I think is important is that when the loved ones of the decedent, you know, aren't sure whether the person committed suicide or had an overdose, it adds to their grief and interferes with their ability to come to grips with what happened. So SAMHSA put together a consensus panel to develop uniform standards and case definitions to help officials distinguish deaths caused by opioids from deaths in which drugs were detected but were not a major cause or contributor of the death. So the recommendations are in 4 areas. The first is in the scene investigation and the collection of evidence and a history. And it's, you know, so often if opioids are detected on a toxicology test, you know, the assumption is that the person committed suicide, but unless they left a suicide note, it's not clear. I mean, I'm sorry, if there's opioids in the toxicology, it's assumed that the person died of an opioid overdose, but unless they left a suicide note, it's impossible to know whether it was intentional overdose or not. So one of the recommendations was to have standardized detection thresholds and the ability to distinguish between acute and chronic drug use. The case definitions include, recommendations for these include a drug-caused death, which is the exposure of the drug alone or in combination with other substances. A drug poisoning death due to the acute exposure of the drug, either alone or in combination with other drugs or substances. And this is the one that's equivalent to the layperson's conception of a drug overdose. The first one could have been drug caused if it was related to other things like a traffic accident or a medical comorbidity that was exacerbated by the drug use. But the drug poisoning death is the recommended terminology for drug overdose. And then there can be a drug detected death in which the drug is detected regardless of whether the drug actually caused the death. And the fourth recommendation is to determine and document the causality, whether the concentration of the drug was fatal or toxic in combination with other drugs, which together were fatal. And, you know, we hear about this sometimes when we're thinking about patients who have buprenorphine or methadone in their blood when they die. And we tend to think, oh, it was a methadone overdose, but in reality, a lot of these patients are also taking benzodiazepines and alcohol. And so it's important to know whether there was a toxicity in combination with other drugs and whether that was contributed to the fatal outcome. And there's subsets of poisonings which are distinguished by intent. And an unintentional drug poisoning is a determination of whether the concentration of the drug was fatal or toxic in combination with other drugs which together were fatal and that could be considered an accidental overdose versus an intentional drug poisoning where the person actually intended to commit suicide or attempt suicide. And then there's another subset of poisoning that's distinguished by intent, and that's assault, where you may have intended to injure or kill someone, including homicidal poisonings. So like I said, without a documented history of depression, and we said earlier that over 54% of the suicides had no documented history of depression. So without a history of depression or a suicide note, it's difficult for medical examiners or coroners to know the decedent's intentions. And when there's 5, 6, 7, 20 overdoses happening in a city in one weekend, they don't, in combination with the stigma of addiction and lack of resources to do forensic investigations, these cases are often not followed up on forensically. So now I want to talk about other conditions that may interact with opioid use and exert cumulative effects. In 2018, the Pain News Network and International Pain Foundation published the results of a 2017 survey that was conducted on the one-year anniversary of the rollout of the CDC's 2016 opioid guidelines. Over 3,100 patients with pain who subscribed to the Pain Network or the International Pain Foundation responded to the survey, and 40% of those reported that they had considered suicide because of poorly controlled pain. And suicide rates, they propose, may have started climbing after the release of the CDC guidelines, and they hypothesized that it was because the pain medications were harder to get and the patients could no longer tolerate the pain without the treatment that they were accustomed to. So we could say that drug overdose related deaths may be, not always, may be a consequence of the undertreatment of both pain and depression. Remember, we said earlier it's difficult to get treatment for your depression. And if you can't treat your pain or you're undertreating your pain and you're depressed, that may lead to opioid overdose related deaths. Another type of condition that may be associated with the opioid overdose and suicide epidemics are social determinants, or the epidemic of despair, and the relationship of those on both depression and drug use. So there's a solid documented association of drug-related mortality with a number of social determinants. And in 2005, Case and Deaton coined the term epidemic of despair, which is defined as an American phenomenon of reduced life expectancy attributable to things like unemployment, poor finances, lack of education, divorce, depression, loss of social connections, and substance use. It has been said that deep-seated social and economic ailments will never yield to medical remedies, and naloxone and drug rehab will never treat joblessness, poverty, lack of economic opportunity, and the homelessness that results. That will require economic, not addiction rehabilitation. And so now we're hearing about a rise of suicidal deaths in the Midwest, where farmers have been unable to plant or harvest their fields because of the floods that still have not receded. And this gentleman in the upper left works with suicidal farmers. He's been doing it for over 30 years. But he said recently that it's becoming too much to bear. And the CDC is documenting farm stress, where farmers' suicides are a rising rural health concern. And some of this is in relationship to the financial losses, both from the weather-related and climate-related changes and floods, disasters, but also things like the tariff situation and deals that are being struck with other countries for to import or export products. And we know that some Americans are disproportionately affected, like in Katrina, when more than 1,800 low-income residents were left dead, and most of them were African Americans, and thousands more were left with nothing. And so the epidemic of despair is an important variable to consider when we're looking at both opioid overdoses and suicides. Another, what I would call cluster of conditions involved in both the opioid overdose epidemic and the suicide epidemic would be the adverse childhood experiences, or ACEs. And in 1998, Folletti et al. Did a study of 13,000 adults enrolled in a West Coast HMO and looked at 7 of the adverse childhood experience categories, like psychological abuse, physical abuse, sexual abuse, violence against the mother, household members with substance use, household members that were mentally ill or suicidal, or household members that were ever imprisoned. And the risk of adverse outcomes increases dramatically the more of these exposures that you have. So if you have 4 or more exposure categories, your risk for things like alcoholism, drug use, depression, suicide attempts, smoking, poor health, physical inactivity, heart disease, diabetes, obesity, all of these things in adulthood can be found to have a 4 to 12-fold increase in health risk among adults who experienced these exposure categories in childhood. And here's some references to linkages to the ACEs to both alcohol and drug use and suicide. So that I just tried to brainstorm another of other risk factors and comorbid conditions that cluster and interact synergistically with suicide, overdose, drug use, or any constellation of these, or both of these. So there's studies that look at ACEs and pain and women who are in SUD treatment, substance use disorder treatment. There's studies about alcohol use and suicidal behavior among people who use drugs, HIV/AIDS and drug addiction, HIV risk and childhood household dysfunction, insomnia, alcohol use disorders and suicide, post-traumatic stress disorders and prescription opioid use disorders, post-traumatic stress disorders, drug dependence, suicidality among Vietnam veterans with a history of drug use, heavy drug use, and the opioid epidemic and the resurgence of methamphetamine use in rural America. And I really just stopped because I didn't want to clutter my screen, but there's numerous risk factors and comorbid conditions that cluster and interact synergistically, making the opioid overdose epidemic and the suicide epidemic being only one of a number of, or 2 of a number of epidemics that cluster together and have synergistic effects. There's many others. So that led me to look at syndemic theory. And syndemic theory is, and the syndemic model of health are helpful in understanding the adverse and synergistic effects of distinct diseases and social and environmental factors that interact and co-occur or occur sequentially in a manner that promotes and enhances the negative effects of those interactions. I'll leave that for a second so people can read it one more time. Okay, syndemic theory can be helpful for describing how certain conditions cluster and interact synergistically to exacerbate health effects, problem severity, or disease progression, and consideration of syndemic interactions and their cumulative and multiplicative effects are helpful in guiding treatment and prognosis for individuals and for program planning and health policy for population health. And Singer is the first person that I know of who wrote about syndemic theory. Wow, I ended faster than I thought, but in conclusion, I'd like to say that all of these are multidimensional disorders with multiple, often overlapping etiologies. So any single-minded approach will be ineffective. And far too often, depending on our funding silo or our system of care or our specialty, we try to treat multidimensional disorders with unidimensional approaches. But because of syndemic theory and because multidimensional disorders often overlap in their etiologies, it's important that we don't limit ourselves to single-minded approaches. And a heightened awareness of syndemic or harmful effects that occur when disorders cluster or interact is important for us to understand, as well as the counter-syndemic or protective benefits that syndemic theory can help us use to lead to appropriate interventions, advance health policy, and improve outcomes. So I'm just going to see if I have one more slide or no. Oh, there's my contact information, and I believe you'll be able to access that on the website. And I have lots of references for your benefit. So I think I will stop on the conclusion page for Dr. Rundio to ask if there are any questions, and then he has some more things to tell you about the PCSS program.
Thank you, Dr. Fanioli. That was excellent. Yes, by all means, we have a question box open. If you have any questions or comments, please post them there, because we have ample time to answer them. There is one comment there right now stating that medical examiners need to check and record fentanyl instead of blaming prescribers for the opioid crisis. And yes, definitely the surgence of fentanyl has increased dramatically. I see that in every time I practice. So again, if you have any questions or comments, please don't hesitate to post that in the question box.
Well, you know, now you can spend about $80 on some of the fentanyl precursors and about $700 on some additional chemicals and create fentanyl with limited laboratory knowledge and limited laboratory resources. You can cook it up in your home just about like people try to do with methamphetamine, and it's being used to adulterate heroin, and it's being sold as other drugs, like it's laced in with methamphetamine, or it's being used to cut other drugs. So unless, and you can easily change one of the precursors of fentanyl to make something like fentanyl that is not as easily detected. So it's kind of like playing whack-a-mole when it comes to having medical examiners test for fentanyl. Are any of the people able to ask a question verbally, or they have to type them in here?
They have to type them in. Yeah.
Okay.
Yep. Now I'm checking both the chat box and the question box. So, Dr. Finero, if you want to advance the slides, I'll talk a little bit about the grant while we wait for some questions.
Okay. So please feel free to ask questions. And
okay, so one of the things that we also do through the grant is the PCSS Mentor Program, which is designed to offer general information to clinicians about evidence-based clinical practices and prescribing medications for opioid addiction. PCSS Mentors are a national network of providers with expertise in addictions, pain, evidence-based treatment, including medication-assisted treatment. It's a three-tiered approach, allows every mentor-mentee relationship to be unique and catered to the specific needs of the mentee. And again, because it is grant funded, there is no cost. So for more information, visit https://pcssnow.org/mentoring/. You go to the next slide. And again, the clinical questions are being posted now. This PowerPoint presentation has been recorded, and it will be available both at the International Nurses Society on Addictions website and the American Academy of Addiction Psychiatry website as well. So anyone can view this presentation for the future. This is a collaborative effort, the PCCSS grant, and you can see that the associations that are represented there. I think there's probably maybe another slide too.
including INSA.
Yep, you see the International Nurses Society on Addictions there. And actually for the next grant period, there are 21 organizations that are part of the grant. INSA, the International Nurses Society Addictions, is one of them. Also, I should tell you too that you will be getting a contact hour of continuing education credit provided by the California Board of Nursing, and that will come to you when you complete your online evaluation. We do ask you to complete the online evaluation, and then usually we send a re-eval 30 days later to see if you retained your learning.
There's some questions that were posted, Al. If you click the questions tab, the little icon to the left of the X, you should be able to open them up and see them better.
Okay.
Before we do that, can I give a shout out to Adrian Jug, I'm not sure I'm pronouncing his last name correctly, Jugdoyle, who is the president of the UK chapter of INSA. And I don't know a lot of people on this list, but I saw Dr. Peggy Compton, who's a longtime friend of INSA. Hello to Colleen LaBelle, who is the current Vice President-elect of the ANCB, who does our CARN and CARN AP exams. And to anybody else that I've missed that I know, just saying hello to friends on that signed in today.
Okay, so here we go. Here's one of the questions. Upon completion, will it be possible to receive PDF copy of the slides for future reference? Normally, we can definitely, yes, Robert said we can definitely send a copy of the slides to all attendees in a PDF file. And that was the same thing. Will slides be available for? Yes, you, again, by sending the PDF file, or again, it's posted on the AAAP, the American Academy of Addiction Psychiatry website, as well as the International Nurses Society on Addictions website. Okay, I mentioned the medical examiner piece. Someone comment, great presentation. Will we have access to the slides following the talk? We addressed that. And here's some more questions. Is there any research highlighting the number of opioid use disorder deaths or suicides with Suboxone or methadone in the system?
The best place to find that information, I think, would be the medical examiner's office in your state. And I'm not sure the extent to which that's documented nationally.
Okay. And another question, any specific suicide assessment would you recommend for use against the suicide, scales or whatnot?
I didn't really focus on that because I was writing for the Policy Watch column of the journal, and I'm sure there are, but if you go to Dr. Oquendo and Dr. Vocal's paper that they published together, I don't have the name of a specific suicide risk assessment, but I do want to mention that there's 3 practice and policy changes that they recommend that can help reduce opioid misuse risk while improving the treatment of chronic pain. And it's sort of not exactly what you asked, but I want to make sure they do exist. I just don't know which ones. But Dr. Vocal and Tom McClellan and Dr. Oquendo recommend that policy changes include increasing the science-supported prescribing and management practices. And I think we need to study about whether there's been a corresponding increase in overdoses or a corresponding decrease in suicides, or a corresponding decrease in overdoses as a result, or somehow sequential to the opioid CDC opioid prescribing guidelines. And there needs to be more prescriber training on pain management and addiction. And they recommend increasing research on pain to include how to mitigate risk in general, but using some of the different packaging and formulations of medications that are prevent people from overdosing from taking medications at higher than recommended doses or by alternative routes of administration. And for example, mixing agonist with the antagonist, or delivering medications in a form that can't be crushed or extracted or combined with other drugs to create an adverse response. But I'm sorry, I don't know the answer about the suicide screening assessment tools off the top of my head.
And here's another question: were the findings similar in other first world countries?
Because it was the director of NIDA and the director of the American Psychiatric Association, the focus of most of the research I looked at was American. I'm sorry, I was American-centric in that. I don't know about other countries off the top of my head.
Okay. And everyone wants to see your contact info, which we will put that slide on again at the end of answering the questions.
Okay.
And then I'm glad you discussed ACEs, which in my experience are an important factor in approaching recovery. And I think everyone would agree with that. What are the recommendations for providers to monitor or screen for benzo abuse? Benzodiazepines.
Well, Al, maybe you can help me with that, but I think one of the problems is that it's overprescribed by people who don't understand the relationship between benzo use and and substance use disorders and pain treatment. And if you've got somebody on a lot of opioids for pain, you need to have extreme caution when treating anxiety disorders with benzos. So I don't know, yeah, can you add more to that?
Yeah, I will. I mean, I work in a residential addictions treatment center, so of course we screen for that. Maybe like in primary care, maybe they're not, but I think what's so different today than even a few years back, we would see people primarily abusing heroin, but now probably 3/4 to more of our patients who come abusing heroin, which is oftentimes laced with benzos and fentanyl, but also are abusing large amounts of the benzos. So of course we screen everyone for that, and then of course doing the urine drug screen will also demonstrate, if they're positive for that as well. But I definitely think in the primary care setting that patients need to be screened for that as well, because there's really a lot of abuse of the benzodiazepines as well.
I think we need to develop better approaches for how we handle the fact that we've been overprescribing opioids and overprescribing benzos for so many years now. And I know people that are going to their primary care provider, and every time they go, they cut their benzo dose in half. And if they really have a panic disorder, they do pretty good till they get down to, you know, one more cut, and they just can't handle it without having a panic attack. So we got them in that situation by over prescribing these drugs. Now we need more research to figure out how to handle things like anxiety disorders without getting them iatrogenically dependent on drugs like benzos and opioids.
Yep. Okay. How do you ensure that individuals have long-term financial coverage in place for opiate agonist treatments?
You tell your legislators to expand Medicaid coverage in your state is the first one that comes to my mind. States that have expanded Medicaid coverage as a result of the Affordable Care Act have significant reductions in mortality and morbidity, and increased rates of being able to seek and access drug treatment than people with similar demographic and other patient characteristics in neighboring states that did not expand Medicaid. So I don't want to turn this into a political talk, but I've been working in public health for over 36 years, and I'm all in favor. And my daughter lives in Australia, where she got insurance within 1 week of moving to Australia that she didn't have before the Affordable Care Act, because she graduated from school and could no longer be on my insurance. So the Affordable Care Act covered her until she was 26. But then if you don't have employer-based insurance, we really need a Medicare for all type program. And some people disagree with that for political reasons, but as a public health professional, I advocate for that because I know patients need insurance if they want to live. So I'm not being political, I'm being evidence-based about my advocacy views about insurance. And I think Medicaid expansion or Medicare for all is the best way we can go about that.
Yeah. Okay. Do you have statistics specific to medication-assisted treatment and/or states or regions of the United States? I would say we don't have that right at our fingertips right here, but that information is available.
And I saw maps the other day on some federal website that showed the progression of opioid overdoses, where, you know, the darker color was the higher rate of opioid overdose deaths. And you could see every year different states were getting darker, and other states that were already, you know, having significant problems were continuing to worsen. So it's funny, there exists such data, but I would look on the SAMHSA has a center for data and research, and if you just look up data on the SAMHSA website, the National Survey on Drug Use and Health has a lot of that kind of data, and it's really interesting to look at changes over time. Like, for example, we've seen methamphetamine go from the West Coast marching gradually across the country till it hits the East Coast. So it exists, but I don't have it at my fingertips either.
Okay. Another question is, and I'll answer this one, how do we access the PCSS mentoring program for clients? What is the process? Again, we can put that slide up at the end, and you would go onto the website and go through that portal to get more information, as well as phone numbers that you can contact. Now, this is a long one, but as a substance abuse nurse, I have experienced challenges in trying to convince some providers treating our clients as to the importance of linking the opioid use disorder client to mental health services. How can we better serve our clients with mental health disorders in receiving the mental health services that may need to be addressed in order to avoid the stressors that can lead to suicide? What are your thoughts on this?
Well, you know, a lot of states are integrating their mental health and substance use disorder services, just like we're trying to integrate with primary care as well. And a lot of our patients receive their mental health follow-up through primary care because of lack of treatment access within the mental health services. So there's no quick fix to give you an answer to this right now. I don't know if you work in the private or the public sector, but each state has a state substance use disorder director mandated through Congress and conditions of the federal funding that they receive. And likewise, there's a state mental health authority, and there's a state opioid treatment authority in each state. So I think a good place to start could be your state agency office for mental health and substance use, and they know what's happening in your state, that we could not possibly answer that for you right now. And there's also publicly funded, meaning federal or state dollars, being administered at a city or county level. It's federal or state money that goes through the state, and it's administered at the city or county level. And there's a city or county substance use disorder director and a person designated for mental health services. And even if you are not publicly funded, they license and certify these treatment programs. So I think that's a perfect place to go. There's also SAMHSA's treatment locators on the SAMHSA website, and you can put your patient's zip code into the treatment locator and find all of the treatment programs in your general area. But I think an important thing that your question gets to is that there's such an overlap between mental health and substance use disorders. When 1 out of 3 or 4 girls have been physically, sexually, or emotionally assaulted before they're 15 years of age, and when somewhere between 70 and 95% of women in drug treatment have histories of abuse or trauma, and a good 60 to 80% of men in treatment have had histories of abuse or trauma of some sort or another. I think, you know, it's important that we just assume that all of our substance use disorder patients possibly have a history of trauma and possibly a concurrent psychiatric diagnosis. And so all of our treatment needs to be more focused on co-occurring disorders and the integration of behavioral health services to include substance use and mental health. But the first place I would start is your state office or your city or county office, even if you're in a private treatment program.
What is the likelihood that the 54% of completed suicides without prior mental health history had undiagnosed mental illness?
Huge, huge. And, you know, it's also huge that that substance use contributed to the overdose death, or that it could have been misclassified. So I think, you know, every service that touches this population is underfunded, from the law enforcement to the coroners to the forensics people to the treatment providers to the prevention services. And we just need to advocate through our professional societies and our local, state, and federal government to try to address some of these issues. And I hope that we've at least increased an awareness of the importance of addressing all of these conditions, or beginning to think about how we can assess and integrate care for our patients to include a multiple of conditions and not just focus on medication-assisted treatment without providing psychosocial support, or putting patients in one-size-fits-all kinds of programs, because women need gender-specific services, and just about all treatment programs need to be trauma-informed, and we need to be assessing for these other conditions, even if that's not what our primary funding stream or silo is. So if you don't mind, Al, I'm going to go back to that final slide of mine that says, they're multidimensional disorders with often overlapping etiologies, so single-minded approaches will be ineffective, but we're not really at a point to know what all of the if it's a multidimensional problem, it requires multiple approaches, and now's a good time to put a plug in for interdisciplinary education in our pre-licensure programs, so that nurses, doctors, social workers, counselors, drug treatment providers, and primary care providers can all start working together to have an integrated approach and a team-based approach where everybody works together for the same treatment plan directions and can speak the language of their other counterparts that interact with these patients, and so that any door is the right door and there's no wrong door when these patients need care.
Okay.
But I'll go back to the other slide if that's what you want to be on.
Yep, and put your contact info up too. Yep.
Are you ready for that now?
Yeah, you can put that up for a
Oops.
minute. And then we'll go
Wait a minute, did I pass it? No, I think it's back here. There it is.
Yep, and then we'll go to the mentoring slide after that. Here's a couple more questions. Is there an increase in suicidality after abstinence?
I would say probably, or it could be. There's definitely an increased risk of relapse leading to overdose.
Yep,
in a
that's
after
definitely
a
what you
period of
say.
absence. Mm-hmm.
Yeah, this is a comment. Great presentation, super important topic. The connection of pain, human suffering, and substance use cannot be understated.
Thank you.
Okay.
Oops.
A few more questions.
I'm not sharing the slide now. How do I get it back? What do you see? You see my whole computer now, don't you?
No, I just see the slides with the small slides too. It's okay. There you go.
But I'm not on the, you wanted to go to the PCSS slide?
The at the end, yeah. It's all the way at the end.
Sorry, I pushed the wrong button.
Mentoring slide. Someone had a question about that. There you go. Back one. Back two.
One more. Okay.
Back one more.
Oh, one more. Okay.
Back one more. Back one more. There you go.
Mentoring.
Yep. This one says, how can we encourage patients with substance abuse disorders to seek long-term treatment? What are the significant barriers to long-term treatments?
Well, one thing is the stigma of addiction, and that's something that I have a real great interest in right now, because people don't feel welcomed or safe to approach their healthcare providers when they have a mental illness or a substance use disorder. And I teach my students not to say substance abuse disorder, because the proper DSM terminology right now is substance use disorder, and abuse is considered to be a stigmatizing term because it implies a moral conduct disorder and a lack of willpower. And so that is a demeaning term, and it's no longer an appropriate diagnostic category. So, but I know that as long as we talk about patients like they're drug seekers or frequent flyers or addicts, then it's easy to label them and dehumanize them instead of understanding that they're patients with a treatable illness and they should be welcomed to our healthcare systems to get the services that they need.
This is a comment. You can query specific drugs at death through CDC Wonder as well.
You're right.
And this was a question. Do you know of an ED nurse-friendly, less than 5 minutes universal screening tool able to identify substance use disorder and mental illness history?
Well, I recommend the first 3 questions of the audit for substance use, and it's the 3 questions of the alcohol use disorder screening instrument. And if the first question is negative, then you can jump right to a drug screen question. And NIDA has a single item drug screen question. But if the first 3 questions of the alcohol use disorder test are positive, then you complete the rest of the 10 questions to figure out if they have harmful or hazardous alcohol use that has not yet reached dependence. I really don't like the CAGE questionnaire that a lot of people are taught in school, because you have to be dependent before it will before it will detect a positive result. And there's the NIDA single item drug screen, and the readiness ruler says, how ready are you to make changes about your alcohol use, your tobacco use, your opioid use, your stimulant use, your prescription drug use, and that allows you to both identify other substances that they might be using, benzos, and whether they're ready to change their use of the substance. And sometimes people are ready to stop heroin, but they're not ready to stop drinking, or they're ready to stop cocaine, but they're not ready to stop smoking pot. And a lot of people are just not ready to stop tobacco. So it's helpful to know which drug they're willing to stop, and allow them to stop those without necessarily being abstinent to everything, because any change is a good change. But then there's the mental health. If anybody emails me, I can send you the single item drug screen and 2 questions to detect psychiatric illnesses. I think it's like, have you ever been told that you had a psychiatric diagnosis? Have you ever been hospitalized or received medication or other treatment for a psychiatric illness? Those 2 questions detect, they're like a pre-screen to mental illnesses. And then there's the MHSF3, the Mental Health Screening Form 3, which a lot of states have used because it has those first level screens for general psychiatric history. And then if those are negative, you can stop. If those are positive, you can ask another dozen face valid questions that each one, if it's a positive answer, it corresponds to a specific diagnosis like schizophrenia, depression, bipolar, that kind of thing. So the mental health screening form 3, the single item drug screen, and the audit questionnaire, not the CAGE, the frequency quantity questions of the audit.
Okay. The VA has some data with respect to increases in veteran studies associated with the aggressive opioid tapering they are doing at the VA, which that's great to know.
Yeah, I'd like to see how they're doing that.
Yeah. It says, what states have been most successful dealing with the opioid crisis?
I don't know that I can answer that without doing some research.
Yeah, I would too. And I
I've
think
been teaching nursing school, so I'm kind of out of some of the state and federal government kinds of issues right now.
okay. It says, what are your thoughts about safe injection sites?
I think if you're going to inject drugs, it's probably better to be near a provider that can assist you if you overdose. And here's my real thought about I'm carrying this over from when, just like safe injection sites are kind of taboo now. I'm old enough to remember when needle exchange programs were both illegal and taboo. And I've been to NIDA funded conferences that talked about harm reduction. And I used to run a street outreach program for out of treatment drug users to either, you know, be referred for treatment and get their HIV testing done. But if they were not ready to stop their use of substances and injections, then we provided, because needle exchange was illegal, we provided bleach kits to teach them how to clean their works. And here's what I learned about that whenever somebody engages in a harm reduction program, like they have to go a certain number of days per week to a needle exchange program to get clean needles, or they engage in the activity of cleaning their needles with bleach and water every time they use, and they make a decision not to share their needles. Every time they do that, they're repeating in their mind the prevention message that someone gave to them, or they're exposing themselves to more prevention messages when they enter a program to go pick up their clean needles. And so if I'm in an alley getting ready to shoot up, but I'm cleaning my works, I'm playing a little tape, a rerun in my head of the prevention message that this is how I clean my stuff with bleach, and this is how I'm doing this in order to prevent the spread of diseases. And if you play that rerun over in your head enough times, a couple times a day, every day for a period of time, 2 years later, these people are more likely to be abstinent than people that we insisted on abstinence for. So abstinence-based approaches are often more ineffective, and I would say can lead to death, because if they go back out on the street and they buy street drugs, they don't know what they're getting, they don't know what the dose is, and they're likely to either be the victim of a violence crime or overdose, or catch a transmittable illness. So I'm in favor of harm reduction approaches.
Yep, I am too. This is just a comment. Mental health services are unavailable. This one, I'm currently enrolled in a DMP program. My project is centered on an integrative healthcare approach for patients in medication-assisted treatment programs. I see patients who do not follow a PCP for their medical comorbidities, and I believe they would be much more compliant with treatment if they could receive care in one place. No.
So the federal guidelines for the substance abuse prevention and treatment block grant funding and the medication assisted treatment regulations require that you either provide or make available those services for patients, and hopefully at the setting where they're receiving treatment. So I'm in favor of you advocating for on-site primary care integrated into the behavioral health setting.
This says, I work in primary care, but just as there is a stigma in treating the substance use disorder clients by physicians, some are still reluctant, not well versed on identifying those clients that may need further assessment. I myself have made many referrals for requests to some of our providers to have a client referred for mental health services because of precisely what you indicated: past trauma, verbalized issues with anxiety and depression, and yet some providers do not get the overlapping issues of substance use disorder and mental health. I will continue to advocate for mental health assessments for all clients that I may treat for opioid use disorder. Thank you for your feedback.
Well, I just want to say that as professional nurses, it's our ethical and moral obligation, our professional obligation to engage in lifelong learning. So I never intended to be a drug addiction specialist. I used to run childhood immunization programs. And one day an outreach worker told me this mom didn't immunize her kid because she was using substances. So I brought in people from the substance use agency to train my maternal child health providers in substance use disorders. And then I provided cross training in maternal child health care and started providing childhood immunizations at the treatment programs where children accompanied their mothers to drug treatment. I knew nothing about drug abuse at that time, but I made it my business to learn it. And some of our interprofessional colleagues don't have that same commitment, but as advanced practice nurses and DNPs and any nurse, I wasn't a DNP at the time. We say, what's the problem? What do they need? How do we fix it? And if lack of education or lack of knowledge or lack of integrated systems are part of the problem, then we need to address the upstream problem and not just try to fit our practice into a square hole. We need to change the environment in which the practice takes place. And it's hard work, but it pays off in the end. And ultimately, I got offered a job in HIV street outreach for substance use disorder services, became a CARN, and found out about INSA, and I've been in drug addiction treatment ever since because I learned that as a public health nurse in maternal child health and STDs and family planning and primary care, every problem I dealt with in public health was related to addictions one way or another. And I didn't know I was going to stub my toe on a rock and take my career down an entirely different path. But 20 years later, this is where I am. And I think you can be the change agent in your organization, and I hope you will. And if you have questions, please email me and I'll try to give you some guidance within my ability to do so, and depending on the volume of emails that I get. But.
Well, Dr. Vernelli, thank you so much for presenting. It was an excellent presentation, great information. Thank you, everyone, for being here.
I'm sorry I didn't have all of the answers to all of the questions, but we can all go look them up afterwards.
Yep.
Yeah.
Google's a wonderful thing.
Thank you all for attending. I appreciate everybody for coming today. And look out for more PCSS webinars in the future, because we just got renewal for the next 3 years, and there's more of these to come.
More of these to come, and we will be doing another one in July. It will be announced shortly. And also, please don't forget when we email you the evaluation to complete it so you can get your contact hours. We appreciate you being here. Don't forget to visit the International Nurses Society on Addictions website, as well as the American Academy of Addiction Psychiatry. Both sites have wonderful resources for all of us so that we can better treat our patients. Thank you for being here, and we will now end the webinar.
Wait, I'd like to say one more thing, Al. If you're a nurse and you're working in addictions, please consider going to the ANCB, the American, ANCB, I'm drawing a blank, Addiction Nursing Certification Board website. You can link to it from the INSA website and consider becoming certified in Addictions Registered Nursing CARN or the Addictions Registered Nursing Advanced Practice CARN AP. And the kind of contact hours that you get for attending these kinds of webinars can help you meet your certification requirements through ANCB.
Yes, and don't forget too, INSA does a wonderful annual conference every year, which is in October. We're in Baltimore this year. Yes. Again, you'll find all the conference information, the dates, the location on the INSA website. So hopefully we'll see many of you there as well.
Yep, become a member of INSA. Thank you, Al, for inviting me today, and thank you all for attending.
Thank you for a wonderful presentation. Thank you, everyone. Have a
Thank
great
you.
week and take care.
Bye-bye.
Bye.